Okay, this is one of the MDC recall questions. Let's see if we can answer it. The question says a patient presents with loss of vision in the right visual field of both eyes. Now, based on these symptoms, where is the lesion likely located? And the options are A, the retina, B, the right optic nerve, C, the optic chiasm, D, the left optic tract, E, the left primary visual cortex. Now, this is an opportunity for us to briefly revise our knowledge on the visual pathway. So let's do that and come back to attempt to answer this question. Now, the visual pathway starts from the retina, the back of the eye, where you have the visual receptors, the cones, and the rods. And these are the ones that pick up impulses and transmit these impulses along the optic nerve through to the optic chiasm, where the fibers proceed to the lateral geniculate body of the thalamus. So from the cones and rods of the retina, you have the optic nerve up to the optic chiasm. Then you have from the optic chiasm down to the geniculate body. This is the optic tract. Now at the optic tract, the fibers further divide, with some going down to the temporal lobe and stop going up to the parietal lobe, and these are called the optic radiations. And these fibers finally converge at the occipital lobe, where we have the primary visual cortex. Now let's get some terminologies out of the way. We seen that this is the visual field. This is a representation of the visual field, circular area which is shaded in different colors, and this is because light from these different areas are perceived by receptors, visual receptors in different parts of the retina. So we have each eye has in its visual field the temporal visual field and the nasal visual field. So nasal, temporal, but each of these can also be named as the right and left visual field. So for the left eye, the right visual field is here, which is also known as the nasal visual field, and its left visual field is also known as the temporal visual field. And on the right eye, the left visual field is known as the nasal visual field, and the temporal visual field is known as the right visual field. So you can see the change in naming as you move from right eye to left eye. But nasal because it is towards the nose, and temporal because it's outside towards the temple, or the temporal region of the head. But it is right and left. Okay, so that is how that visual field is configured. Now the central visual field is located here, just right at where my cursor is showing. Right, that's the central visual field. So we'll see why this is important in a second. Now, with this configuration, you have light rays that are coming from the nasal visual field. So let's take the left eye, for instance. Light rays that are coming from the nasal visual field of an object that is being perceived are intercepted, or are received and interpreted or picked up by visual receptors which are located at the lateral part of the retina, which is this region. And then light rays that are coming from the temporal visual field of the left eye are perceived by visual receptors that are located in the nasal part of the retina, just like that. And same thing applies on the right eye. Now this is important because the configuration of these fibers, it follows in the same pattern. So when you have these fibers that arise from the lateral aspect or the temporal region of the retina, carry these temporal fibers and they travel in that direction. And these ones that carry stimuli from the nasal aspect of the retina travel in that same direction. So travel in the nasal or in the medial direction. Now when you arrive at the optic chiasm, you have some form of a decussation of these fibers. So the nasal fibers on the right cross over to the left, and then those of the left cross over to the right, and then they join the temporal fibers of the contralateral side. So this one crosses over here and join with this. This one crosses over here and join with the temporal fibers here. So that is your optic tract, optic chiasm. Then from the optic chiasm, when you now have these fibers crossing over and joining the other side, you now have the optic tract, and that extends from the optic chiasm all the way down to the lateral geniculate body, which is this dot here where my cursor is. Now at this lateral geniculate body, you now have the optic radiations, and these optic radiations are a further division of the optic tract into an anterior, also known as the lateral fibers, and these are the ones that pass through the temporal lobe around the Meyer's loop. Then you have the posterior fibers, also known as the medial fibers, and these go up through the parietal lobe. So this is a division of the optic tract into these radiations, and these radiations are called the optic radiations. So the upper radiations which pass to the parietal lobe are the posterior radiations, and then those that pass through the temporal lobe are the anterior radiations or the lateral radiations, and then they both converge at the optic, the primary visual cortex, which is occipital lobe. Right. So having identified these pathway, let's see what could happen and what the visual defects will be, and in the various lesions that may arise. Okay, so with this, the first kind of visual defect or visual field defect that you might have in somebody who might be having some form of defect in the visual pathway is ipsilateral enopsia. Now this is how it will look like on the visual field examination. The person will have total loss of vision on the affected eye. So this is a lesion occurring in the optic tract. Optic tract lesions will cause a complete loss of vision on the affected eye. First of all, just even before we jump into lesion from the optic tract backwards, you can have lesions arising from the retina. So retinal lesions, but these usually not cause a complete loss of vision in the visual field. So you usually have isolated visual loss, and these are called scotomas. So you can have somebody having a retinal detachment, for instance, or macular degeneration. So these are, degeneration of these visual receptors around the macular region, and so these will cause isolated visual or patchy loss of vision in the visual field. But having said that, now let's proceed with the rest of the optic tract. So which will start from the optic nerve itself. So the optic nerve damage will result in the complete loss of vision in the affected affected eye. So you have ipsilateral enopsia. So ipsilateral because it's on the same side of the lesion, and this is how it will look like. So lesions such as optic neuritis and patients with multiple sclerosis, for instance, will have present with this kind of visual loss. Direct damage to the optic nerve itself, so traumatic atrophy, for instance, can cause complete loss of vision in the ipsilateral side of the nerve. You can also have patients who have optic nerve atrophy, especially in glaucoma. They will also have this kind of visual loss. Papilledema, for instance, will also result in such complete loss of vision in the ipsilateral side. But then typically you might have papilledema resulting in bilateral because if it's especially from raised intracranial pressure where you have it affecting both eyes, so you have bilateral visual loss. And then you have thromboembolic phenomenon. So somebody who is having an emboli lodging in of the retinal vessels, for instance, can also result in a complete loss of vision in the affected eye. Right. So that is for the optic tract, lesions occurring at the optic tract. Now, lesions occurring at the optic chiasm, they will typically result in what we call a bitemporal heteronymous heminopsia. And this is how the visual field defect will look like. So that is lesion arising somewhere here. So this is how the visual field defect will look like. So it's bilateral. I mean, it's bitemporal because the visual loss is occurring in the temporal regions of the visual field. So bitemporal. And it's heteronymous because it is right on the right eye and left on the left eye. So it is left and right, which is hetero. It's heteronymous. Right, and it's hemianopsia. Hemi because it's half of the visual field that is affected. So the dark shaded regions are the one that are lost. The light regions, the person can still perceive vision around those visual fields. Now, why is this the case? We said at the middle here, you have fibers that receive, that is these fibers. So nasal region, they receive light sensation from the temporal region. And the same thing over here too. And we say these fibers travel medially. So when you have a lesion occurring in the medial around this area, impinging on this part of the optic nerve at the region of the optic chiasm, you have this bitemporal heteronymous heminopsia. Right. So what kind of lesions are typically, would typically result in this? So lesions that are occurring around the sellar region or the sellar testicle. So that's where you have the optic chiasm around the pituitary. So pituitary adenomas, for instance, will result in can result in this kind of visual field loss. You have craniopharyngiomas too, can also result in this. So suprasellar lesions, so even a meningioma arising from this region can also impinge on the optic chiasm and result in this kind of visual loss. You have people who have even parasellar region lesions like internal carotid aneurysms, for instance, can also result in such visual field loss. Right, so the third type of visual field loss, which is this one here, so it's what is called the contralateral homonymous heminopsia. Now, it's contralateral because the visual field loss usually occurs at the opposite side of the lesion. So here, let me just change this color. So here is the lesion is arising on the left side, but then when you look at the visual field, the defect is on the right side of the visual field. So you can say temporal here and nasal here, but it is right visual field on both sides. So it is right on both visual field, and that's why it's called homonymous. Homo means same, so right. And it's contralateral because the lesion is on the left optic tract, but then the defect is on the right visual field, okay, or both eyes. So, and it's heminopsia because it's half of the visual field. And so this is what you have somewhere here. So this one typically have lesions such as CVA, so strokes involving the medial cerebral artery, will result in this kind of visual loss, and you typically have this contralateral homonymous heminopsia. All right, now let's look at the fourth lesion, which is contralateral upper homonymous quadrantinopia, and that is this type of lesion here. So now contralateral, as we said, is because it's on the opposite side of the lesion. So this usually arises from damage to the optic radiation. So if it is upper, it means that the damage is on the lower radiations or the lower optic radiation, and these are located in the temporal lobe. And we'll talk about the lower homonymous type. So just so as there's a lateral inversion here where you have rays from the right ends up on the left side of the retina, and those from the left end up on the right side. It's the same thing with radiation from the up. So light rays from the up of the visual field end up at the bottom, and those from the bottom end up at the upper. And so that's why you have lesions on the lower resulting in an upper visual field loss, and those that will occur in the upper radiation to result in a lower visual loss. Now, why is it a quadrantinopia, or is it a quarter? So it's a quarter of the visual field that is lost. Remember here that this is a complete visual loss. Up here is a complete visual loss because it's both sides that are involved. Here it was half because half of the fibers here cross over to join half of here. And so when you damage here, you have half from each side. Now these halves, after the lateral geniculate body, further split into two again. So you now have half of the halves and so you now have a quarter of that. So if you divide half into 2, you have quarter, and so that's what is happening here. So we have a quadrant, so a half of the halves that we have. So you have a quadrant, which is a quadrantinopia. So contralateral upper homonymous quadrantinopia. It's contralateral because the lesions are on the right. The visual field defect is on the right, but the lesion itself that's causing it is on the left. So strokes involving the temporal lobe, for instance. So this is so anterior cerebral artery, middle cerebral artery lesions can also result in that. So middle cerebral lesions that causes the stroke in the temporal lobe can also cause that. So you have even brain tumors can also cause that. Brain tumors arising from the temporal lobe can also impinge on these radiations and result in this kind of defect. So the opposite is true for the other one, where we have contralateral lower homonymous quadrantinopia. So this means that the lesion is occurring on the upper half of the optic radiations. So that is, and these are located in the parietal lobe, as we said. So when that happens, you have this kind of visual field loss, which is kind of an opposite of what is happening in the previous one that we discussed. Right, and then you have the fifth one, which is the sixth one, which is this. There's contralateral homonymous heminopsia with macular sparing. Right, so this typically occurs in lesions that are in the primary visual cortex itself, so the occipital lobe lesions. So when you look at it, it looks just like this. It looks like the third lesion. It looks like lesion arising from the optic tract. The difference is that in lesions in the occipital lobe itself, you have macular sparing. Now, we said the macular area is the central part of the vision, the visual field. So that is this ring area. So when you draw the visual field like this, the macula is in the center like this, and then you have these other ones which are now in you have the temporal here, and then the other region, then unshaded region is the nasal part. Now fibers from or light rays from the central visual field hit the macular region of the retina, and these fibers terminate at the macular region of the occipital lobe. This region has a dual blood supply, both the middle cerebral artery and the posterior cerebral artery. Most of the occipital lobe is innervated by or is supplied by, it has a blood supply from the posterior cerebral artery. So if you have a posterior cerebral artery infarction, for instance, where you have the occipital lobe being hit, you have loss of vision that resembles this, but because the macular region has supply from the middle cerebral artery, you realize that place is spared, so you have macular sparing. And that is this kind of visual field that you get, this visual field loss that you get. All right. Right, so now let's revisit that question and see if we are able to answer that based on the knowledge that we've gotten. So the question says, a patient presents with loss of vision in the right visual field of both eyes, and we are asked to determine the side of the lesion based on these symptoms. So first of all, it means that the loss of vision in both eyes, we said, is on the right. So this is how it's going to look like on the right. So if you draw this, right visual field loss is like this. So, and if you come here to, it's like this. On the right eye, it's like this. Right. So this is how the loss of visual field will look like. And with this, if you go back to our diagram, our previous diagram, that looks like this. Sorry, that looks like this. Let me use a different color. That looks like this, right? And with this, we said the lesion is occurring at the optic tract, And because it's on the left, on the right, it means that the lesion is on the left. It's contralateral. So the third, contralateral homonymous heminopsia. All right. So now options again. The retina obviously is not correct. The optic nerve, right optic nerve, that's not correct too. We have the optic chiasm, the left optic tract, and the left primary visual cortex. Now we said with the visual cortex itself there will be macular sparing. Okay, so that would have looked something like this with macular sparing. So this is not correct. We can rule that out. We can also rule this out because this will result in scotomas. This will result in ipsilateral anopsia. This we said will result in bitemporal heteronymous heminopsia. So it leaves these two options. Now our question never really gave us any specific as to whether there was macular sparing or not, but your answer is between these two. And so in that situation, you are better off choosing this option because the question did not give any specific as to whether there was macular sparing. But these are the two possible answers that you could get. So if that question went on to say that there was macular sparing, then obviously it's going to be this. All right. So I hope that gave you some information on how to answer these questions on visual defect that arises in the visual pathway. All right. Thank you.